All right, let's get started. So today we're looking at hormone-related infertility, and ooh, what bad timing. Apologies about that. And infertility is quite a big topic, and to cover both male and female infertility in its full spectrum in one webinar is a lot to take in, but let's see how far we can navigate this thing. We're going to look at mainly the hormonal causes and not structural causes. So these are my disclosures as usual. We put them up. So if you look at infertility as a definition, it's the inability to conceive following unprotected sexual intercourse. So the time scales vary. If you're dealing with individuals or a couple below the age of 35, then they need to be trying by themselves for 1 year. And if you're having couples above 35, especially the female partner, then they need to be trying for at least 6 months. So I'm going to put a very interesting fact out there. So whichever suburb you're living in, and I literally tell my patients this, if every couple had to have sex every day, and there's too many of you, and for me to change a screen and go and see by show of hands how many of you are going to get this right. But if you had to guess how many couples, fertile couples out there will fall pregnant having sexual intercourse regularly in your suburb, it's about 20%. So human fertility is not very high. We're not too good at this, and there's various reasons for it. And so if you're trying by yourself with a rate of about 20% a month, in 6 months, you should have sorted this thing out. And if not, that's when we need to start looking at some causes. So about 15% of reproductive couples, that's over 6.1 million couples out there, do have a problem. And men and women are affected equally. Now, that statement can be a bit skewed based on where we're looking, and I'm going to touch on that a little bit. So about 2% of child-seeking women between the ages of 20 and 44 were unable to have their first pregnancy. So this is defined as primary infertility. You just haven't had a pregnancy. About 10% of women who've had a successful first pregnancy will have difficulty in their second pregnancy. And so that's secondary infertility, which means we know a lot of the things were working the first time, and now there's secondary issues. So I said I'll touch on this. Generally speaking, I tell my couples 1/3 of the time it's a male issue, 1/3 of the time it's a female issue, and then 1/3 it's a little bit on both sides. But when we're looking at fertility, remember the STD rates in a country, especially more with women than men, are going to affect the status of the fallopian tubes, and that will influence in terms of whether it's affecting females more in that particular country or is it more males, but that's more a structural problem. And so if you look at it from a point of view of endometriosis, certain population groups are at higher risk of estrogen dominant lesions, and so that will skew the results as well. But you won't be far off if you say it's a third, a third, a third. Now, this is an important thing because we live in a very non-matriarchal, a patriarchal society, and then I'm going to generalize here, but a lot of males just think they're fine, and it's mainly a female problem. So we need to move away from that. And certainly when I start working with a female, I tell them I want to see the male's results as well, because you don't want to be starting to work on your female patient and then realize that it's a male issue, and then the male sperm is going to take 72 or 90 days to get sorted, and that just delays everything. So it's important to know that you're going to be dealing with two sides of a coin here. This is just an overview to say that there's quite a few male factors in terms of infertility, and then there's a lot of female issues as well. We can have structural issues like the testes just didn't descend, And of course, because the environment's warmer there, you're going to get testicular atrophy, and that's going to be an issue. You can get blockage, and so there's no way that the sperm can actually get through, which can become an issue. There can be varicoceles. That affects, again, the temperature. Sperm needs to be basically brewing in a lower temperature. But the rest of the causes are hormonal, and we're going to touch on that. Female perspective as well. There can be issues, damage to the fallopian tube. Like I said, chronic STDs. You may have had a previous ectopic pregnancy. It can be structural issues related to scar tissue or endometriosis. There may be cervical issue. Fibroids can affect infertility. And then there's hormonal issues as well. So we're going to try and touch on these and see how far we can go. So by far, the endocrine abnormalities that lead to infertility are actually not difficult to treat. And so the treatment can be quite rewarding, both for you as a treating physician, but of course, mainly for your clients as well. So let's touch on some of the etiologies of infertility. So if we're looking at women of reproductive age, generally between 15 to 44, fertility is approximately halved between the 37th and 45th year. And this is because of what happens with ovulation. 20% of women have their first child after the age of 30. So gone are the days where, women having children between the ages of 19 and 24. Women have empowered themselves. A lot of them have careers now, and then they've got the ability to delay having their families. And in fact, in first world cities, the average age for a female to have a child is actually 41. So 1/3 of couples, so that's a female thing, right? 1/3 of couples over the age of 35 will have fertility issues. And either because there's ovulation will decrease as you get older, but male sperm quality decreases. But generally speaking, fertility's gone down because there's way too much estrogen in the environment. So we're going to touch on the concept of estrogen dominance, but also if females are getting too much estrogen, and that means it's affecting the whole follicular and luteal phase. It causes more endometriosis, more fibroids, more first trimester miscarriages. Remember, too much estrogen in males is not good because it affects fertility as well. So by and large, fertility in males have halved in the last 2 generations. So if we're looking at females, you have basically problems with ovulation. I touched on tubal disease or uterine disease or cervical factor. Here we're looking at mainly more structural problems. Uterine fibroid acts no differently besides the whole hormonal issue behind the causes of uterine fibroids. It's acting like a Mirena or a copper IUD. Endometriosis, here there's an added effect. So it can be a structural problem. It can be a problem where it's affecting implantation. But of course, endometriosis is a milieu of inflammation, and that can affect fertility as well, besides the common endocrine cause between these two and basically the need to ovulate and implant. Autoimmune conditions, vitally important. There can be antibodies to basically sperm. There can be antibodies to basically the egg and then gamete as well. Any chronic inflammatory conditions, whether it's autoimmune conditions, whether it's diabetes, obesity, can have an impact. And we're going to touch on that at the end. I'm going to give you a slide. And then thyroid is actually an easy treatable cause of infertility. And yet they haven't put it in, but high prolactin levels as well. But I'm going to touch on that. So what would be the complete hormonal evaluation in your female client in terms of what you're going to be testing for? So DHEA must be important if that is the orchestra and that controls and manages all the sex steroids. Um, Cortisol, flight and fright, important. Hormone, very important. Thyroid controls the entire body's metabolism. We're going to touch on LH, the luteinizing hormone, follicular stimulating hormone. That's the guy that's going to make the egg. Estradiol, progesterone, and its relationship with each other. Prolactin, androstenedione, beta-HCG, and AMH levels. So this would be a general hormonal screen, and based on the patient's phenotype and family history, I add Hormone index as well to this one. So touching on the basic physiology, this is the hypothalamus. Structurally, it would be up there in the brain, and it produces a hormone called GnRH, gonadotropin releasing hormone. And what it does is then it stimulates the pituitary gland in a way where it's going to influence FSH. It's going to cause an increase in it, and the FSH is going to have a direct effect on the ovaries to produce more follicles. I consider the pituitary gland to be non-binary, and so FSH will have the same effect in males, but this time it obviously produces testosterone. The GnRH also then activates LH, and we're going to touch on the importance of LH and in males and females, but the net result is in the male, we have increased production in testosterone and sperm, and then testosterone will have a negative feedback in the GnRH. So in other words, if there's too much testosterone, negative feedback, and it will downregulate this axis. If the LH and FSH is also getting to produce egg and estrogen and progesterone, and if you've got too much of any of these, then it's going to downregulate the cycle. So what is a contraceptive? What is a form of contraceptive for females? It is a contraceptive pill. And what does it have? It has high levels of estrogen and progestin, and that basically then will switch off the GnRH, LH, FSH cycle, and that's how it acts as a contraceptive. If you give males testosterone, too much of it, and it downregulates the GnRH axis, and that's going to act as a contraceptive in male. This is vitally important because I'll tell you, 2 years ago, I had a couple coming to me from one of the fertility clinics in Senton, and one of the senior gynecologists actually put the male who was having erectile dysfunction on testosterone, and you go figure, because he's going to have very strong erections, but it's going to be shooting blanks. So don't take that for granted. And this is a fertility clinic. From an FSH perspective, so let's touch on FSH, follicular stimulating hormone. Stimulates the development of an egg, females, and if you want to, and you're managing fertility couples, the third day of the menstrual cycle, you'll do an FSH, and it gives you a good indication in terms of what's happening downstream. It is used to evaluate egg supply because remember, FSH, follicular stimulating hormone, is going to recruit new follicles to become ripe. So too high or too low will signal fertility issues. In men, it's used to determine sperm count, and if the FSH is very high, that means the testes is not making enough, and that's why the pituitary gland is trying to upregulate itself to force the gland to make it. It's the same picture we see in postmenopausal females. The thing that causes hot flushes is a high FSH because the ovaries can no longer make eggs, but the pituitary is trying to stimulate it to do so. And so a high FSH in males and females will tell you that there's a problem with the ovaries or testes. If it's too low, that means you're getting no signal from the pituitary, and that means you cannot stimulate, so you're losing the trophic effect. So for those of you who've attended any of my webinars in the past, and we were talking about hormones in endocrinology, it's very interesting. Either side of any hormone is a problem. Too much thyroid, too little thyroid. Too much cortisol, too little cortisol. Too much testosterone, too little. Too much estrogen, too much progesterone. It's a problem. It's about having balance and trying to get the mid range. That's very important. And so FSH regulates the production and transport of sperm in males. The luteinizing hormone. Now, it's all well and fine that you're making an egg, but you need to release it. So LH stimulates the release of the egg from the follicle. And in men, it stimulates the hormone testosterone, which will then affect testosterone production, but also important for all the other sex organs in a male. The LH surge may cause undesirable changes in egg quality. So too much of an LH surge is a problem, and not enough means you're not going to release the egg. And you can test for these. Now, if you look at day 3 FSH levels, again, if they're high, it means there's ovarian failure at some level, and that means we're not going to be getting enough eggs. A level below 10 to 15 at day 3 seems like that pathway is working well then. You can look at estradiol in the early phase around day 3, around day 21, and even mid-cycle, depending on what aspect of that hormone you're looking at. But generally speaking, too much is no good. Estrogen dominance. And so in the early phase, you're expecting a low level. Inhibin, exactly what that name, the hormone tells you, it inhibits. So too little is a problem. Too much, well, not too much, but a level above 45 is going to be good. And later I'm going to try and touch on inhibin. If I forget, you guys can just remind me. Inhibin is a very interesting hormone. It's produced because, like everything else in life, life's a competition. We are fighting for the best mate. We are fighting for the best kill out there. And from a survival perspective, so when that ovary is trying to recruit new eggs for this particular cycle, there's going to be quite a few recruits. And then inhibin, one guy is going to produce inhibin basically to try and arrest the rest. And basically, you'll end up getting one mature follicle. AMH is a good surrogate marker in terms of quality and the amount of the potential for the amount of eggs that can be produced. So, of course, a low level tells us there's a low ovarian reserve for eggs. And then you can do some stimulation tests. I would say reserve this for the gynae or for the endocrinologist. And then if you're going to try and count how many follicles, you need an ultrasound, which means it's mainly going to be done by gynaes. Once you've got more than 3, 4 antral follicles, then you have quite a few potential ones, and you'll hopefully get at least one. Whereas if you're starting with very few, you're in trouble already. Estradiol is both a male and female hormone. Of course, females have more of it, and it's there to stimulate the growth of the follicle and the production of the cervical mucus to make it more receptive for the sperm to enter through the cervix and get into the uterus. But the main function is to prepare the uterine lining for implantation of the egg. And I've got a picture for that, and we're going to touch on that. So as they develop, the levels continue to rise. They're talking about they in terms of the follicles, but also the lining. And this rise can further indicate that the oocytes within the follicles is reaching maturity. So a follicle is going to have an oocyte. And then as it becomes larger and larger and larger, once it gets to between 18 and 22 millimeters, it's looking like it's ripe. And that means the oocyte's probably mature. You have an LH surge, which I'm going to touch on. And then you're going to have a release of that particular egg. Estradiol is vitally important form of estrogen. For those of you who've attended my webinar on estrogen dominance, and Leonie can correct me if I'm wrong, but I think it's somewhere on the web or she's got the link to it. If you give somebody pregnenolone, which is what I call the grandmother molecules of all the sex steroids, and you do a Dutch test, you will get 24 different metabolites of estrogen. Estradiol, and so you get three main categories: estradiol, estrone, and estriol. This is one of the most vital forms of estrogen. And so to test this will be important, and we're going to go through some ratios. But essentially, this is important to make the uterine lining, and that's where your egg is going to basically end up sitting. Now, estradiol will vary from person to person and from day to day in your cycle. So you cannot rely wholly on one absolute value. And we've done talks on PCOS recently. We've done talks on estrogen dominance, and we've spoken about that in detail, and we've gone through many case studies. But remember, I told you historically as well, we spoke about too low not being good, too high not being good, but each hormone has a partner. TSH, T4, DHA, cortisol, estrogen, progesterone, insulin, glucagon. There's a relationship between these. So the ratio between estrogen and progesterone becomes important. So blood levels can't always be interpreted with complete certainty in the first cycle without prior cycles to calibrate the level. In other words, you can't just look at one level and hope you've got the answer to this client's solution as well. Sometimes you need to be looking at trends, but vitally important would be the symptoms associated with these hormones. So you talking about probability rather than an absolute level per cycle. And so the levels can range quite a bit, and you have different reference ranges from different labs. But by and large, if you look at the reference ranges in South Africa, for the follicular phase, you're looking at an average of around 200. For the luteal phase, you're looking at around 350. And during that surge in the mid-cycle of ovulation, it can go up to 700. And so you can choose a day that you work with, and based on why you're doing it, you can look at the ratios. So if you look at day 3, day 21, mid-cycle, and some people do these different tests for different reasons, and we're going to touch on that, I think, on the next slide. The important thing is to know the relationship with one hormone against its partner hormone, which is progesterone. Okay, just leave the other ones. So you can have levels that change on a daily basis, and then the cyclical variations. I just explained that, the follicular phase and the luteal phase. But other conditions and drugs can influence this as well. So patients with blood pressure, anemia, impaired liver or kidney function, they all affect estradiol levels. Remember, this guy gets metabolized there, and we're going to touch on that. Drugs can affect estradiol levels. Cortisol, it's a sex steroid. Certain antibiotics, estrogen or estrogen-like containing compounds, phenothiazines, tetracyclines, these all have a potential of increasing estradiol levels. So as promised, we all remember this from our 3rd and 4th year physiology books, and let's touch on that. So on the bottom, you're looking at a 28-day cycle, and not everybody is expected to follow the lunar cycle, right? And so what's important is that, does your client always have a 30-day cycle? Is it always a 32-day cycle? Is it always a 27-day cycle? So a predictable number of days is what's important. This is just considered the ideal from a textbook perspective. So what do we have? So you've got estradiol slowly going up in the first follicular phase of the cycle, and we said that that's important for the follicles to be forming, but also it's going to be very important later to build the lining. So you can see slowly the lining is climbing, and so you've got the one surge just before ovulation, and you needed that spike because that spike in estrogen stimulates the LH to spike as well. And remember, you needed the LH spike to release the oocyte. Then the estrogen drops. Now, you'll notice some of your patients will tell you they know when they're actually ovulating. So that estrogen surge is going to, especially in people who are estrogen dominant, is going to be higher, and they will tell you, actually, I know it came from this ovary, and I had breast tenderness, or I was more horny, or whatever. And so there's a point to this, right? And so that surge will obviously get the female to start going into estrus. We see this in animals. I just came back from the Kruger, and basically all of them are pregnant now. Nature plans the cycle for spring. And so from that perspective, that estrogen serves many functions. One is to allow maturation of this egg, that oocyte to grow, and then that acts as a precursor, besides the GnRH signal for the LH to surge. That's going to release the egg. Now, hopefully, that egg's got a place to go and sit. So that lining had to become thicker and grow and become more vascular and get ready and get ripe. Well, there's that estrogen serving that. And we mustn't forget FSH role. So the FSH is basically there to make these follicles. And then the progesterone becomes very important as well, because that estrogen progesterone ratio is going to allow implantation, and that progesterone is important. Later, this is going to end up adding to progesterone, and then later the placenta maintains progesterone levels then throughout pregnancy. So you can see a strong interplay with different hormones, but the important thing is the relationship between these two hormones. So look at the ratio there and there, and then the ratio between there and there becomes very important. So women with low progesterone on day 21 was 60% less likely to achieve pregnancy naturally. Hormonal imbalances like estrogen dominance, so too much estrogen, or low progesterone is quite common in females with subfertility and recurrent pregnancy loss. It's overlooked and it is easily modifiable. So it's amazing. I had a visiting prof who we get along very well with, and chemical pathologist. And I think about 2 or 3 years ago, when I was still at Barra, we were chatting about concept of estrogen dominance. I wanted to do a sub-study as part of my thyroid stuff. And she said, no, that doesn't exist. So I said, of course it exists. And said, but show it to me in the endocrine literature. And the pathologist confirmed that to say, no, we did a study in one of the rural areas north of Gauteng, and we looked at the females, and there was no estrogen dominance. So if you don't define estrogen dominance and its relationship to progesterone, you'll never know it exists, because I told you estrogen levels change every day and they vary from cycle to cycle. And so the symptoms are very important as well, because if you're going to wait for the fibroid and the adenomas in the breast and the endometriosis, well, then we're a bit late on the take, right? So whether you call it estrogen dominance, progesterone deficiency, the ratio ends up causing the same thing, right? The symptoms may be a bit different. So both of which are hormonally driven causes of infertility, commonly undiagnosed, and it's especially seen in women with irregular cycles, luteal phase, that's the second half of the cycle defects and early pregnancy loss. Hormonal balance is critical for fertility. They shouldn't have used the word estrogen. Estradiol builds the endometrial lining and promotes follicular growth. Progesterone prepares the uterus for implantation and maintains early pregnancy. Imbalances will lead to a shorter luteal phase defect. There will be no implantation or improper implantation, and thereby leading to early miscarriage. How do you define estrogen dominance? Elevated estradiol levels relative to progesterone. So it's not always a high estrogen, because it could be that the estrogen's here, and you guys can look at my face for now instead of the slide. And so estrogen can be there and progesterone can be here. So the estrogen was normal, but the progesterone was low. So the progesterone deficiency gives an apparent estrogen dominance. Alternatively, you can have normal progesterone levels, but the estrogen is too high. Still, the body is experiencing it as estrogen dominance, right? So from that perspective, the concept ends up causing the same thing. But a high estrogen, the symptoms will differ slightly to low progesterone. So the symptoms won't all match. Some are unique to this state, some are unique to that state, and some are common to both. And I've given this talk before, this webinar on estrogen dominance. And so where do we see the situation? So it's, sorry, no, not where, what happens? So you can have chronic anovulation, like you'll see in PCOS. You can have luteal phase defects, so the second half of the cycle is too low, which means you haven't had enough time for making a nice, ripe uterine layer. And you can have poor ovarian reserves with the progesterone output. This is important. So remember, estrogen, well, most hormones are cleared in the liver. And so I'm going to show you the importance of having a good detoxifying pathway in the liver, phase 1 and phase 2, because that's where estradiol and estrone and estriol are metabolized. And then, of course, we mustn't forget the influence of xenoestrogens on this entire estrogen dominance as well. So for those of you who haven't attended the webinar on the estrogen dominance, and people say, where's the proof for it? You don't need proof. Classic example in terms of what's happened in terms of change of physiology. For thousands of years, millions of years, humans were starting puberty, females, around 15 to 16. And then in the last 4 generations, you can see it's coming earlier and earlier and earlier. Science and physiology and evolution is not going to change for me and you. We're only on this planet for maximum 60 to 80 years. This shit's been going on. Whenever you're in trouble with any form of biology or physiology, just try and look at the evolutionary pathway and work out why things have adapted to the way they are. There's always a beautiful explanation for it, right? So there's no way physiology is going to change for you and I in the last 4 generations, which is between 40 and 60 years. And for millions of years, the system's been playing one game. So how have we changed the system? We've forced cows to give us milk. How? By adding estrogen to them. That means their meat, bulk, milk, butter, cheese, yogurt, dairy byproducts all have more estrogen. It's not normal for a hen to give you an egg every day or second day. That estrogen is coming through into the meat and into the egg. Those of you who've heard of this, just take a bit of a break. Those of you who haven't, females that go on a contraceptive pill have to pee. They pee out the estrogen. That estrogen is getting into the groundwater. Water purification systems cannot remove the stuff. So those are all real estrogen. And I'm drinking it, so I'm becoming estrogen dominant. The females on this webinar are drinking it. That means they're becoming more estrogen dominant. And life would have worked out perfectly well if we threw some progesterone in the system as well, but we didn't. So now there's too much estrogen and the body cannot produce enough progesterone in all individuals. Hence, This is changing. Now, if you believe nothing that I've said, that's one of the explanation why younger girls are bleeding earlier and earlier. You got girls going into puberty at 9, 10, and 11, and that's becoming more and more common. That's estrogen dominance, right? And so that same issue plays out with a higher risk of breast cancer, higher risk of fibroids, higher risk of endometriosis, higher risk of breast adenomas. That is why your great granny said, no, but you guys are just weak. We were stoic. We never had this. We never complained of breast tenderness. Yeah, they just had less. And then there's a whole lot of xenoestrogens. And don't forget, insecticides, pesticides, and herbicides and heavy metals are all xenoestrogens and plastics. So lots of trouble out there. Now, I got sidetracked there, sorry. Progesterone. So you can test for progesterone, right? Gynaes will tell you day 21 of the cycle or 7 days post-ovulation, because the ovulation is always not going to be on day 21. There's ways of working it out, body temperature and looking at cervical mucus and looking at some blood tests. But when you're sitting with a low level, you know you're going to end up with a luteal phase defect. The estrogen and progesterone ratios par excellence in terms of working out pure estrogen dominance. For somebody who doesn't have a lot of experience in this field, you won't go wrong if you do it mid-luteal phase, so around day 21, and just look at the estrogen progesterone ratios. And we showed you in the other picture, that's what we're looking at here, right? Okay. But for those of you who've been on the other webinar, basically you can work it out anywhere in the cycle, because the ratios in the first half of the cycle are 1 to 20, second of the half of the cycle at least 1 to 10. So high estrogen, low progesterone, what happens? Thick but unstable endometrium. When the progesterone is low, we're having luteal phase defect and implantation failure. And when progesterone is low in the early pregnancy, there isn't enough to maintain it. You've got corpus luteum failure, and so there isn't enough being produced. Whereas if the corpus luteum is working well, it will produce progesterone until the placenta starts making its own, and then it carries it through the pregnancy. What are some of the interventions we can do? Well, you can use bioidentical progesterone, and please, it's not progestin. And you can support the luteal phase, and you can use anything from 25 to 200 milligrams. And the wise homeopaths amongst you will use chasteberry, because that has an influence on LH. Once you have that surge, you have a guaranteed ovulation, but also supports corpus luteum. We should all try and avoid xenoestrogens, not only for fertility, get the liver to start working a bit better so that you can improve estrogen metabolism, but you can also decrease estradiol conversion to bad estrogens. And then we need to address anovulation as well. So if it's from PCOS, one needs to consider lifestyle activity, weight management, decrease stress, improve ovulation, decrease the hormone index, and that can be done using any one of, and we've discussed this when we had our webinar recently in PCOS, right? So par excellence, everybody knows about metformin, but you can use off-label the SGLT2s and basically the GLP and GIP combination agonists. Remember, they have to be stopped before when the patient falls pregnant or just before. Inositol, we spoke about chromium, cinnamon, HCA, D-chiroinositol, berberine, goat root extract, vitamelon, MENA, inositol, D-chiroinositol, myoinositol. These will all help PCOS, but go and watch that webinar. So, case study. Endometriosis is common. 35-year-old, chronic pelvic pain, stage 3 endometriosis, pain on intercourse, infertility is confirmed. They've been trying forever and it's not happening. What's the pathophysiology? You've got local inflammation. There's adhesions, because every time you have endometrial activation, and then in the luteal phase, once you bleed, they regress, the scar tissue, creating adhesions, and then it can affect the fallopian tubes, the inside of the uterus, tissue outside, which can influence the ovary and restrict oocyte pickup, and then affects implantation as well. What have we been doing commonly? The gynae is going laparoscopically, either laser it or remove it, and in some patients that works. Are we treating the underlying condition? No. That means you might get a pregnancy, it's not guaranteed, but the long play on the breast cancer, adenomas in the breasts, ongoing fibroid issues, symptoms, weight gain in the midriff area, pigmentation, zits in the T-zone are all still in play. That excision only removes the active endometrial tissue at the time by the gynae. So what's the long-term play? So indole 3-carbinol and DIM, very important in terms of assisting in the estrogen-progesterone balance, but its main function is to decrease conversion of estradiol to estrone. Calcium D-glucarate, estrogen is metabolized in the liver. Some of it is passed into bile, gets collected into the gallbladder, gets released into the intestines, and based on your gut microbiome, and this is all proven stuff, certain bacteria will, so there is now an estrogen molecule that cannot come back into circulation. So the body is actually getting rid of it through bile, right? However, based on your gut microbiome, that estrogen can be changed to become bioavailable and reabsorbed through the gut and recirculated, and calcium D-glutarate decreases that. These are sulforaphanes. This is the highest concentration of sulforaphanes you're going to get with 2 servings on the planet at the moment, and that helps clear the ill issues of estrogen. Betaine, which is TMG, trimethylglycine, and methionine, also helps the detoxification pathways as well. Liver balance, this has got about 7 items in it. It's got NAC, the highest dose of NAC in a combination product, 750 milligrams. It's got myrcthycil, it's got kudzo, dandelion extract, alpha lipoic acid, vitamin E, and I'm forgetting something, phenols. It's got green tea extract. All of these designed to help certain parts of phase 1 and phase 2 liver detoxification. And then for the ones who need more NAC, you can add that separately, and typically I can go up to 3 grams based on what the patient problem is. So all of those are available for liver detoxification. So that's a quick overplay. So in summary, too much estrogen, too little progesterone affects the entire fertility cycle, and it causes structural problems as well, and it can be managed. And go and watch the estrogen dominance webinar, and you can empower yourself and use it in your practice. However, if you not comfortable, then you can pick these issues up and then just refer appropriately to your referral doctor. Now let's touch on thyroid and fertility. So hyperthyroidism affects the cycle. That is an overactive thyroid from whatever cause. And if you had to take 100 people, generally about 21% of people, females, will have problems with a cycle. So I'm saying, let's say you take 100 females, you take 12 cycles. Not every cycle is perfect in every female, right? So generally out there, about 20% of healthy people may still have a problem now and then with a cycle. They will miss an ovulation thing. Rarely they can have 1 or 2 cycles in a year with menorrhagia. But if you had to compare it to people with hyperthyroidism, 50% of them have these issues. And this was published in these particular studies. So fertility and miscarriage can be influenced by follicular growth, embryo implantation, and developmental issues, and placental formation. Now, we touched on how estrogen, progesterone, LH, FSH affects us, but thyroid also affects every one of these pathways. So whether it's the early phase, whether it's the luteal phase, or even post implantation later, thyroid function can affect all of this, and there's the publication in reputable journals. AMH. This is looking at reserve of eggs, and so women above the age of 35 will generally have lower AMH levels than somebody who's 25, but this is looking at the relationship between thyroid and AMH. So normal TSH is 0.3 to 4.95 or 4.5, depending on which lab you're looking at. And this study shows that when the TSH goes above 1.4, it already identifies a decrease in AMH levels. And for every 1 unit increase in TSH, in other words, if this goes from 1.4 to 2.4 or to 3.4 or to 4.4, the increased odds of having an MAH lower increases by 25%. So every time this number goes up, it's going to affect ovarian reserves. TSH, the association between an elevated TSH level, so that's an underactive thyroid, and or other autoimmune aspects of thyroid, will have an impact on infertility and ovarian reserve. Two retrospective studies shows the benefit of getting the TSH to treat TSH above 4, because generally all your guidelines will say patients with Hashimoto's or an underactive thyroid, you're going to wait for the TSH to be above 10 and a T4 level below the reference range before you're going to treat. But from a fertility perspective, it's a bit different. So these two studies showed that there is benefit if the patient's TSH is above 4. It doesn't have to be above 10. And then two randomized controlled studies failed to show the benefit in obstetrics in terms of outcome in females with just thyroid antibodies. So positive study, negative study, but then here's other studies showing that patients now with normal thyroid function, but antibodies that are positive, are higher in females who have miscarried. So if you take 100 females who've miscarried, and you haven't done any blood tests, but you go back and you look at their thyroid antibodies, the ones who had higher thyroid antibodies had higher risk of miscarriage, higher need for artificial insemination, higher need for IVF, and higher risk of miscarriage. So even when you had a patient with a diagnosed underactive thyroid, you had them on T4 replacement, and it was adequate, and the antibodies were positive, that in itself influenced miscarriage. So to test for thyroid antibodies would be vitally important, and it affects fertility in many ways, either through ovarian dysfunction, but also the whole fetal placental unit can get affected, and I think it's important. Let's look at premature ovarian insufficiency and general autoimmunity. So 4 to 30% of females with premature ovarian insufficiency. So let's say you happen to have a big infertility practice and you've got 100 patients with premature ovarian insufficiency. 4 to 30%, depending on your practice, will have an autoimmune cause for it. So in the future, there is a need for a non-invasive, reliable test to speak to the autoimmunity aspect of premature ovarian failure, be it antibodies to the ovarian steroid cells, thyroid antibodies we can always do, because that would then bring in the possibility of coming in with immunosuppressant therapy to dampen those and then thereby trying to reactivate that ovary before it gets fibrosed. This is interesting work. So you've got a patient with an overactive thyroid. For whatever reason you chose, right, this patient's got Graves, and the doctor said radioactive iodine. The radioactive iodine has worked, the thyroid has become underactive, you started treating the patient, and now the thyroid level, according to TSH levels, is adequate. If you look at the menstrual irregularity in the first year after radioactive treatment, 12 to 31% of the patients will have menstrual irregularity directly as a result of that. 8 to 16% will have amenorrhea in the first year. And females went into menopause 18 months earlier if they chose that form of treatment for Graves. AMH concentrations were lower. So although they were lower, it didn't influence pregnancy rate in this study. So from that perspective, it has some effect, showing of interest that it's affecting various parts of the fertility cycle. So it will be important. So routine testing for antiphospholipid is something that is being done because it's associated with recurrent pregnancy loss, and you can put the client on low dose aspirin for that. But anti-sperm, anti-nuclear is not routinely tested for. And anti-thyroid, if there's a family history or a miscarriage, then you can do it. Otherwise, it doesn't account for it routinely. And here I'm going against what the slide is saying. I say do it anyway. You don't want to pop 100 grams IVF and you realize that there was a simple issue where the thyroid antibodies were positive. So what the hell can you do if you've got any autoimmune condition, whether it's rheumatoid arthritis, lupus, dermatomyositis, Sjogren's, autoimmune hepatitis, alopecia areata, Hashimoto's, Graves' disease? Selenium has been shown to decrease antibody levels, and there's various products on the market. This one has 200 micrograms of selenium plus gugolipids and a bit of vitamin D, all of which to influence the immune system. And I think last year we did a whole topic on thyroid, and then we covered thyroid antibodies, and I had real live cases from Lancet and Empath showing you guys the before and after. And in 70% of patients with any autoimmune condition, although this guy is called thyroid balance, selenium will work for all autoimmune conditions. In 70% of the cases, it will reduce the level of antibodies. And I showed you guys the studies. Vitamin D is very important. For many years, Harry Seftel and I used to wrestle on the Nolene show, and he's my prof, and I love him to bits, but he was a good guy to debate stuff with. And he was famous for saying, vitamins are inexpensive urine. So all of a sudden, when COVID came and the whole world thought they were dying, every one of us remembered our third year lectures to say vitamin D is very important for immune system. And prior, the year before that, most doctors told you, don't take anything, it's expensive urine. So when the world was being threatened with death, all of a sudden we remember the importance of vitamin D, when it was always sitting there in our third year lectures. So generally speaking, most people will need 3,000 units a day, but it's what you're trying to achieve. So I try and get an average of at least 50 to 60 on the reference range on most of my patients. Anything between 20 and 30 is adequate for bone, but for immunomodulatory properties, for metabolic conditions, for cancer patients, to decrease autoimmune conditions, reference ranges are different. And again, we did a topic on vitamin D, but that would be important. So this is the case study we had actually used previously when we spoke about, oh, I didn't give you guys a talk, sorry. I gave a talk to actually the Infertility Society online talk because I was on holiday, and there's a case study I used. 26-year-old female with a history of miscarriage, family history of Hashimoto's, struggling to fall pregnant. Family history, guys. So there's more than one family with Hashimoto's, right? She's already had a miscarriage, already proven to struggle to fall pregnant. This is a second marriage, and husband already fathered 2 children in the first pregnancy. What's her tests? TSH of 5.9, T4 levels are normal, not on thyroid treatment, thyroid antibodies positive. Do you treat or don't you treat? I treat. So the patient goes on to thyroid balance. You wait about 6 months to see whether it's worked. 70% of the patients, the levels will come down. You continue. If it doesn't, you can stop it. In terms of TSH, I would treat. You start with low dose of your favorite T4. If the T3 levels were low, you can come in with a bit of T3 as well. Again, that's a talk completely on its own. And then you aim for a level of 1 to 2 from a fertility perspective. And then you wait and see what happens. Now, I've only got 2 or 3 slides on PCOS, although PCOS is one of the commonest treatable causes, hormonal causes of infertility in females between the ages of 18 to 35. I just did a whole webinar on it, I think less than 2 months ago, right? So this is just a touch. How do you diagnose it? The Rotterdam criteria. It was a negotiated panel decision. So you've got some cyclical problems, oligo or anovulation. You've got evidence, biochemical or clinical, of hyperandrogenism, and ultrasound will show poly, not one, poly. So most gynaes are married to the ultrasound, which is fair because I'm married to my blood tests. And so they would rely on this as the main diagnosis. Most of us don't have access to that. And remember, you only need 2 out of 3. So you could have these 2 and still have a diagnosis. You can have these 2 and still have a diagnosis. You can have that one and that one as well. And this is plastic. It moves, it changes, right? And so it's dynamic, because sometimes I get clients saying, the gynaes didn't know what they were talking about. The one said I got PCOS, the other one said no. Hello. You might have been more insulin resistant at a certain phase in your life. You were not exercising. When you went and see the gynae, and then you had 48 cysts, and they said, yeah, you got it. And then you may have changed your mind. You started becoming more active. You lost a bit of weight. Somebody put you on metformin. You go to the next gynae, and the cysts are gone, and they say, you don't have it. So the cysts will come and go based on the cause. We discussed the cause. The basis of it is insulin resistance, right? And so 28-year-old female, irregular cycles, hyperandrogenism, diagnosed with PCOS. The mechanism is insulin resistance and high LH, which leads to follicular arrest. That means instead of one follicle becoming ripe and mature to 18 to 22 and beat the rest to the game, you got a whole lot of them arrested between 8 and 12 millimeters. So nobody's going forward, and you're just sitting with a whole lot of cysts, right? So management is lifestyle, 10,000 steps a day, stress less, watch your high GI carbs, take something to improve insulin resistance, and see what happens. Now, some people will use a contraceptive pill, we went on it, to regulate the cycle, and that means you're making all those cysts go away because it's acting as a contraceptive, right? And again, we touched on how to manage it. Go back to that webinar. Prolactin, nature's contraceptive. That's all you need to know. You see, 10,000 years ago, when there was no NAN, no powdered milk, and no spa around the corner, and your partner was pregnant, nature needed to make sure of the survival of the person who delivered the child and the child. Otherwise, the game ends. Now, if there's no spa around the corner, there's no guaranteed hunt, you might have 1 or 2 long winters. How are we going to be guaranteed to have enough food and milk to keep the host and this one puppy alive? There was no condoms. So the same hormone that produces milk was going to act as a contraceptive, by and large. So that way, if you don't prevent a pregnancy while you're still nursing the first one for the first 18 months, the chance of that species surviving becomes more. Because we're not good hunters. We may believe we are good hunters. We're the weakest hunters. Go and look at the Hadzas of Tanzania in Africa and look at their success in terms of hunts. Look at the cheetah. But these guys are all much better than us. We're the slowest animals, one of the slowest mammals. Even the bloody hippo runs faster than us. But just from that perspective, if we couldn't chase too much down, that's why we needed the spear, and then we became a bit more successful. We needed a form of contraceptive. There's prolactin. So prolactin is a hormone that plays an active role in stimulating milk production after the delivery of the child, but it increases during pregnancy and works to inhibit ovulation. And I'm telling you, I get couples that have gone through 1 or 2 IVF cycles, and I go back and I look at what the IVF clinics have done in terms of whether the full investigations were done. And some of them haven't even had a prolactin done. And I have had cases where we've done the prolactin and it was high, and all it was a little bit of meds, and 2 months later, they were pregnant. In fact, I'll let you in on something where even you and I as doctors can get fooled. So years ago, when I was running the Barra circuit, a colleague of mine, physician, they were struggling to have a baba. I was running the circuit. Obviously, they as a couple didn't want everybody to know what they were going through. But I'm the guy who gives you time off the circuit in terms of whether you're going to get leave or not in your rotations. So this guy comes to me and he said, listen, we need to go to Cape Town. So I said, how long do you need? We need X amount of time. So I've got to make a break for this guy here now. And so it's like they went for many cycles. But, you know, somewhere along the line, I asked him, I said, but listen, you guys sure you guys have checked everything? Sandeep, we've checked everything. Fine. Anyway, shame these guys have tried and tried and tried. Nothing happening. The long and short of it is they ended up adopting a child. And then we were chatting about a business deal, and he had a few issues. So I said, send me your results and then send me your wife's results as well, because going forward, the fertility stuff is now sorted because you guys adopted a child, but there's other issues that you need to be dealing with as well, because the hormones that cause infertility are going to cause other issues as well, whether it's weight, cardiovascular, or whatever. Lo and behold, staring at me, tested more than one time, is a high prolactin. And so I went and I hit him on the head and I said, what the hell? You told me all the hormones were fine. Yeah. The IVF clinics all told us everything is fine. There's a physician who spent thousands, went to every IVF clinic, eventually having to fly to Cape Town, and all we did was we sorted out, and then they had their own kid. And so don't take it for granted. That's why I put up that list there as well. You don't make assumptions that the last doctor checked everything. Go and check the old results. This is a very important one. And you know why? Because it is the easiest, one of the most gratifying things to see when a couple's been struggling for 6 months, 2 years. You pick this up, you give them a small berry tablet once a week, and it's like magic. 8 to 12 weeks later, they're pregnant. And so high levels will stop ovulation. It will cause the menstrual cycle to eventually cease, but you don't have to wait for it to cease. It can just affect ovulation as well, right? And it can cause intermittent ovulation as well. And it can take a long time for ovulation to occur as well. So it affects quite a few parts of the cycle. And so from that perspective, very important. Now, when you look at this test, you need to understand that it also has diurnal variation, that it peaks during REM sleep and early in the morning. Levels will rise after exercise. A high protein meal can cause a surge. Sexual intercourse, breast examination. If I always tell my patients, listen, is your man a breast a man or a butt man? If it's a breast man, he's got to stay away from the breast for a while because it will stimulate the prolactin. Certain surgical procedure, post seizure, the prolactin will go up, and stress and drugs, certain drugs. I think there's drugs here somewhere. You can go through it. So when you got high prolactin levels, and just check your lab's reference, it's not rocket scientist stuff, this. It promotes lactation, and so thereby suppresses the GnRH, which decreases LH and FSH, and that means it's going to act as a contraceptive, right? So definitely it was planned, it was by design that it to act as an infertility hormone. And so it does so with these three factors in women, but also in men, guys. One of the first things you have to check in men with low testosterone, exclude hyperprolactinemia and an underactive thyroid. Those are two quick, easily treatable conditions to get the testosterone up again. But yeah, this will affect men as well. And in all ways, it will drop the testosterone, affect the libido, affect the erections, and affect sperm count and quality. So this is just looking at it another way. So pregnancy pushes up prolactin, stress, nipple stimulation, sleep, seatbelt injury, pathological. So seatbelt injuries, use of cannabis, cannabis drops, gummies, antipsychotics, opioids, high doses of estrogen, antidepressants, exclude a prolactinoma. So generally speaking, some people say above 50, I say above 80, you're looking at possibility of prolactinoma. So then refer the client on. Severely underactive thyroid can cause prolactin to go up, and stalk compression, right? You got a tumor, you got a mass, compresses on the pituitary stalk, and that causes prolactin to go up. Okay, these cases you have to refer. You can't try and manage it. Diagnosed with no clear cause. And then there's a whole lot where you've excluded everything, but the prolactin's still up. Doesn't matter, because you're going to see the treatment's the same. So 30-year-old female, amenorrhea for 6 months, producing a bit of milk. So you don't have to, but when it's very high, they're going to be producing a bit of milk, even though they're not pregnant. Infertility, prolactin was high, LH and FSH were abnormal, pregnancy test was negative, you do an MRI, and there's a microadenoma. And the treatment, gabapentin, 0.25. So whether it's 0.25, 0.5, 1 milligram once a week, or half a tablet twice a week, whatever it is, it's based on the level. And within 6 to 8 weeks, recheck the level, adjust the treatment, and it's going to be like magic. Hyperprolactinemia, one of the most treatable causes of infertility, with a success rate above 80%. Save your client that 100 grand IVF cycle, guys. Males. So 38-year-old male, low libido, fatigue, infertility, levels of 45. It could cause testosterone to go down. LH and FSH is suppressed, sperm count down. Do an MRI, you found nothing. Same treatment. And then once the prolactin's down, check your testosterone levels. If it goes up, wait it out. 72 to 90 days later, you're sitting with good sperm. So diagnose it with a blood test. Exclude other causes like a pregnancy, medication, high TSH, and all other things I listed. Above 50, do an MRI of the pituitary gland. If there's an adenoma, refer to your favorite endo. Dopamine agonist, that's the drug I spoke about. This is long acting, so you can use it once a week, sometimes twice a week, as opposed to bromocriptine that needs to be used once, twice, or 3 times a day. And then you recheck and then check your sperm or your ovulation. Now let's look at the adrenal gland. There's the hypothalamus. There's the pituitary. The hypothalamus produces a hormone called CRH, cortico-releasing hormone. So what does it release? it releases ACTH from the pituitary. The ACTH then goes to the adrenal gland, gets it to wake up and produce corticosteroids, cortisol, flight and fight hormone. Now, although the lion is the king of the jungle, and I just came from the Kruger, when it mates, it's got the shortest interval. It's like less than 20 seconds, but it mates like about 30 times in a day. Even the king of the jungle knew that his most vulnerable time in his life, from an attack perspective, was when he was mating or when he was sleeping. And so that's important. Now, go back historically. Why did we evolve? Why did your maker give you this cycle? Flight and fright. So there's a lion chasing you. There's another tribe coming with their weapons, and they're about to kill you. You activate the flight and fright response. That's number one. But you also, so that was quick, finish. They kill you, you kill them, or you go up a tree and you run away, finish. And the transaction is short and quick. However, if you've got a long winter, that's going to be a bit stressful. So that's chronic stress. And chronic stress acts as a contraceptive. This is my theory, by the way. So there's no scientific proof for this one. So from that perspective, when you look at it, do you think that if you're going through a winter, do you think it would be wise for that female to fall pregnant? Because a long winter means your hunts are going to be less successful, less stores. You're using up the stores you got to warm up, right? Burning more fat. Chances of you falling pregnant, maintaining the pregnancy and delivering and having enough food is very little. So cortisol thereby switches the axis off or affects the axis and then down regulates fertility from that perspective. The problem is nowadays there's no lion and another tribe coming to kill us. There's no long starvation for most of us, but your stresses are even more. It's chronic. It's long hours, a shit boss, a nagging partner, bad neighbor, malema, you name it. All the shit is here, right? So from that perspective, here, chronic stress is a very important cause in the modern day from a population, from a fertility perspective. But there's many other pathways. Besides inducing apoptosis of the granular cells and oocytes, it's been shown to increase oxidative stress and accelerate the activation of the follicles. That means they'll be releasing too soon, and there's no place for implantation because that endometrium wasn't thick and ripe enough. So high cortisol, low DHA in infertility, that is what I call the missing link. And so cortisol is made in the adrenal cortex, rises in response to stress. DHA is also built in the adrenal cortex, acts as a neurosteroid, an androgen precursor, and high stress will cause cortisol to go up. It will steal the DHA. This will suppress the GnRH, affect LH, FSH, poor follicular development. Spermogenesis also gets affected in the male. Implantation is a problem. Luteal phase defect. This has been shown. So low DHEA and its impact on fertility. So I've been using DHA from an infertility perspective, probably now 26 to 28 years. And a lot of the gynaes used to shout me because they say high androgens is going to affect their oocytes. But I think they were mixing up androgens. And then later the studies show an elegant study from Delhi, which is the government capital in India, and Harvard, within a 3-month period, both groups published a paper showing how DHA actually improve AMH, egg reserves, and ovulation. And then the problem was the one study was a rat study, so they took the milligrams, equated to humans, and now the females are getting too much. The literature tells you 25 to 50 milligrams for females. Well, you sit with females with beard, very upset, and then some of them do make eggs. So too much is also no good, remember. So it supports ovarian follicles, it modulates AMH, influences ovarian reserve, but also improves immune tolerance. Remember, DHA balances Th1, Th2 receptor function. We did a webinar on this as well. And so women with DHA on the low end of the reference range had 35% lower IVF success rates versus the controls. This was published in 2023. What about high cortisol? Also suppresses the GnRH, LH, FSH, decreases estrogen and progesterone, almost acting as a contraceptive, but not 100% contraceptive. Now, the interesting thing is the high cortisol blunts progesterone production. Go back and look at your sex steroid pathway. It's a steal pathway. So when cortisol go up, it steals the precursor from the progesterone line, and that's going to go down. And if you don't have enough progesterone, you're going to have luteal phase defects. And so it's very interesting stuff. High cortisol also increase inflammation, oxidative stress, which will affect quality of egg and sperm as well. So in men, it's linked to reduced sperm motility, so the guys don't swim, and the morphology. And in women, it's been shown to delay ovulation and increase risk of anovulation. I think this is just putting the whole thing together as both high cortisol and DHA, and I've just touched on that. And so how would you treat it? Again, we did a whole talk on the adrenal gland, right? But high cortisols, you can bring it down to ashwagandha or rhodiola. If that's not enough, you can use phosphatidylserine. If that's not enough, pregnenolone. If that's not enough, send them to Kim for cognitive behavioral therapy, breath work, box breathing, parasympathetic breathing, ice baths, and optimize sleep. Anything to activate the parasympathetic pathway, which will then, through the vagus nerve, calm the cortisol levels. Low DHA, well, that's easy. So I ignore this amount, right? Just ignore this amount. So you guys have been taught this. Females, you can use 10 milligrams, 12.5, 15, 20, 25. Start low and build up until you in the mid-range, around 3.5 to 4.5 for the female. And in males, you can go from 25 to whatever dose you need and try and get that to the mid-reference range. And when this DHA cortisol ratio or the cortisol DHA ratio is better balanced, then game on from a fertility perspective. Female patient with high cortisol, low DHA, 35 years of age, high stress job, failed 2 IVF, irregular ovulations. You look at the 8 AM cortisol, very high, DHA low, Cushing's was excluded, AMH low, FSH elevated. This is all bad news. Poor sleep. Patient is going to be anxious. Early luteal phase spotting. That means they start spotting, not bleeding, earlier than they're meant to have the menstrual cycle. You can use ashwagandha, high doses of omega-3, low doses of DHA to get this to between 3.5 to 4.5 in the morning. And I would use rhodiola as well to try and bring this down. And then 3 months later, I review and we'll see what happens. And then hopefully if the levels are right, and this is the only issue, the cycle will resume. Let's touch on endocrine disruptors. It's all over. You find it everywhere. It's associated with low sperm count, low oocyte quality. implantation failures, miscarriage. This exposure is modifiable somewhat with lifestyle and product choices, and there's growing evidence to support routine environmental history and tests in the future in terms of infertility workup. I promised you guys that towards the end, I will show you how diabetes and obesity affects fertility. Stick with me. It's a very busy slide, but let's go by step, right? We've touched on another webinar, obesity and diabetes. What's the link here? Environmental factors, genetic factors, lifestyle factors. They all contribute towards obesity, insulin resistance, and diabetes. The underlying cause for this is insulin resistance. In a female, that makes the basis of PCOS. PCOS will have high androgen levels, will have chronic anovulation, affect the cycles. Obesity in females, increased sex hormone binding globulin, increased insulin levels, hyperestrogenemia, estrogen dominance. This, and this will lead to endometrial problems. Your IGF-1 levels will generally be affected. That has a direct impact on ovaries, and the high estrogen and the low progesterone is going to be affecting everything that we spoke about. So it affects female infertility in many ways. For males, it's interesting because obesity means there's more visceral fat, more stores available for testosterone to convert to estrogen. The high estrogen will affect the axis, and it will alter production of sperm. The high estrogen directly will affect sperm quality and production. Insulin resistance, inflammation, and chronic oxidative stress by itself affects testosterone production, and micro and macrovascular complications with diabetes in itself can affect erectile dysfunction. So many factors can affect infertility both in males and females. So what happened there now? Sorry, so it's not finished. So now let me touch a bit on the male. So in males, you can have varicose seals, so send them to a radiologist for embolization or a urologist. In terms of azoospermia, there can be genetic causes like Klinefelter's, where actually you've got a genetic problem that leads to the either hypothalamus or pituitary not working. You can have other endocrine causes, and then obstructive, send them to a urologist. This I've touched on, endometriosis we touched on, air pollution, very important. Leonie didn't have enough time to download onto my presentation a few of the slides that I sent on air pollution. Lots of work showing how air pollution affects the gamete and the embryo. Of course, in an IVF lab, but even outside of the IVF lab as well. So varicose veins, easy to sort out. It causes infertility because the scrotal heat goes up, higher temperatures, oxidative stress, impairs sperm, surgical manipulation by the urologist. So let's touch on the male now. I spoke about how high prolactin can affect men as well. We spoke about oxidative stress in all of us, and here it will affect quality of sperm. Through that, it will also affect the adrenal gland. The adrenal gland will affect the whole axis. It will affect the hypothalamic and anterior pituitary adrenal axis, and that influences downstream Sertoli cell, germ cells, Leydig cell, and they're the ones who produce sperm. Thyroid can affect weight. Thyroid controls metabolism in the body, so it directly affects either through prolactin or by itself infertility. The obesity created from thyroid condition also increases adipokines, decreases leptin, affects inflammation, interleukin 6 and 12, and downregulates this whole axis as well. We touched on diabetes, but what I'm saying is that there's many factors that can affect this. And so I touched on prolactin, and you can treat that in males the same way as you're going to treat in females. So no real change there. From a stress perspective, no real difference in terms of how you're going to treat males and females. Hyperthyroidism and sperm. How does it affect the testes? It decreases the number, decreases the motility, and causes abnormal morphology of sperm. How come? Because the overactive thyroid affects Sertoli, Leydig, and germ cells. So it affects the entire testes. But it also influences the accessory gland. Remember, altered secretory activity is important. There's no good producing sperm. They need food to survive. So the fluid that's produced by the prostate to nourish this is a problem as well. And hyperthyroidism reduces the volume of that. An underactive thyroid affects Sertoli, Leydig, and germ cells, and the net effect is decrease in morphology, and then has a stronger effect on the accessory glands. There's reduced weight, reduced volume, and decrease in salicylic acid and fructose, the food the sperm going to need for their mitochondria to swim to the female. So I'm just going to give you a quick overview in terms of male. They're easier to treat. Let's first talk about quality. NAC and acetylcysteine, precursor to glutathione, mops up free radicals. Free radicals affect quality of sperm. Vitamin D has been shown to be important in every aspect of life. High ferritin levels. So typically I want my male patients to be sitting between 60 and 80. Extra ferritin increases, extra iron stores increases free radical production, but extra iron also goes and sits in the pituitary, thyroid, heart, liver, pancreas, testes. So donating blood and bringing this thing down helps. And then magnesium, well, controls 400 things. These guys also need to swim to the female, and magnesium is important. Homocysteine balance. What does homocysteine balance have? So a high homocysteine indicates poor methylation. And so a level above 6 for me means the methylation is not perfect. And so what's going to improve methylation? Try methyl glycine. So this product has the highest TMG dose in the industry, but it also happens to have methylated B12, B6, highest level of methylated folic acid, and it's got a few other things as well. So the methylation pathway is very important. Now, you've got a male. It wasn't a thyroid problem. It wasn't a prolactin problem. The guy hasn't abused steroids before. So you have to have an approach in terms of how you're going to improve fertility. Improve the DHA levels and bring down cortisol. This will improve libido, quality, and quantity of sperm. How do you, so then you check your testosterone levels, and if the testosterone levels are low, that means the same hormone, LH and FSH, that are responsible to make egg and estrogen is responsible to make sperm and testosterone. So if the testosterone is low, that means the pituitary signal must be low for sperm as well. So when you have low testosterone and you excluded thyroid and prolactin and high ferritin levels, then, and you've improved the DHEA and cortisol, then you say, okay, yeah, you're going to have to try and improve this. So before you do that, you look at the testosterone estrogen ratio. And if the ratios are off, bring the estrogen down so that you don't waste the testosterone. But that anastrozole will also kickstart the GnRH, LH, FSH cycle, and has the potential of improving sperm production. Failing which, you can use clomiphene citrate. So this acts at the level of the hypothalamus, activates LH and FSH, and that can make sperm. But remember, I told you the pituitary is non-binary. So it's going to make more estrogen as well. So keep an eye on what you need to do with the estrogen. Failing which, you can use beta HCG, anything from 500 to 1,000 to 1,500 units 3 times a week. It's a subcut injection. And 72 to 90 days later, have a look at the sperm. But you don't want to wait that long. So after 4 weeks of using this, check your testosterone. If it's gone up, you're on the right path. Carry on, and hopefully it will produce enough sperm. Or you can use recombinant beta HCG. So it's more long-acting, 250 milligrams Orbitril, injected once a week, and 72 to 90 days later, you should be producing sperm. Again, these two are non-binary, so keep an eye on what's happening to estrogen as well. Growth hormone and its peptides have been shown to improve fertility as well. And I can tell you, there isn't a good study showing how some of the vitamins being punted to improve growth hormone. Remember, growth hormone has 6 predictable spikes in a day, each one lasting just 3 minutes, and then the half-life works it for about 30 minutes. So you've got 6 30-minute periods in a day where you can possibly get the growth hormone to go up. In my opinion, that study was very inferior because instead of looking at IGF-1, which has got a half-life of 16 hours, they looked at growth hormone that has a spike of 3 minutes. So, of course, people are going to have a low growth hormone. We test 100 men. Most of the time, you're going to hit it when they don't have a peak. So that you're going to say, these guys are all low. And so if you wanted to show that your product actually brought growth hormone up, then you should have done an IGF-1 before and after the clinical trial and show that the IGF-1 went up, and that is what improved the fertility. But by and large, there's no real oral secretagogues. There are new oral peptides that have come out, but otherwise it's an injectable one. So then we were supposed to go to this slide. So, Leonie can be dramatic and she makes these fancy slides. So the next talk is liver, an amazing organ. So please register. This is how you can get hold of her, by emailing Leonie on this email. And if you want CPD points, this is the link you need to go to, and she will sort it out. I think you're getting 2 CPD points for this. Okay, so this, I basically saw this slide at about 6:44. That was about 15 minutes before we went online. So you're going to have to read it with me fully. So there's a case study given by one of you guys, obviously wanting to remain anonymous. So I've been struggling with unexplained infertility for nearly a year. Had my Mirena removed in 2024 due to wanting to fall pregnant again and experiencing cramps again. So she was pregnant before. Water retention and inflammatory pain. So all was premenstrual estrogen dominant sign. I have a 3-year-old, so she did fall pregnant, and I fell pregnant without any trouble the first time. So now she's falling in on the 10% that's having failure with the second pregnancy, right? So it looks like the infertility is due to multiple eggs, not PCOS. So I'm confused because that's the same thing, right? So in PCOS, you've got multiple follicles, means multiple eggs. All of them can reach full potential. So when you're estrogen dominant and they induce an IVF cycle, you can get something called multiple eggs, where it's hyperovarian stimulation. And unfortunately, in some patients, it can lead to a hypoovarian syndrome. and can cause trouble. And so from that perspective, whether you mean multiple eggs from stimulation during IVF or multiple follicles, we're dealing with the same issue here, estrogen dominance. And so making many, many eggs and not one being released. So there you go. So you're sitting with a lot of these eggs between 8 and 12 millimeters, and none of them are going to release because they never mature to the 18 to 22 millimeter size. And then you didn't have that L8 surge, and so you're not going to have the release. Background, I have an underactive thyroid treated with desiccated armor, normal antibodies, vitamin D, B12, insulin, all extra were optimal levels, tested in February. Attached are the results. I had my EBOS hormone metabolite test around February, showed many adducts, showed attached, was on liver balance, estrogen balance, Vivo mix for 3 months. I have not retested due to being or put on medication after the initial test. Metformin 1000 BD, letrozole 2.5 milligrams for the first part of the cycle for 3 months to improve fertility. And that's to induce basically the hypothalamus to produce more LH and FSH, and then that hopefully that should make more eggs. I've done genetic testing, have some SNPs in the COMT and methylation pathway, so that's the detoxification pathway in the liver, and I have known more than one estrogen, and she's got estrogen dominant profile. I've also been resistant to weight loss for the last 6 months. I'm not overweight, 58 kilograms, 167. I had to, BMI is probably 24. But I have about 3 kilograms more fat than I used to have, despite my best efforts. I was put on a compounded progesterone by my doctor to take between day 10 and 28, but my gynae suggested to stop it. So it's almost like a Dutch test, but done by the doc in Potchefstroom that I told you guys about. So on this particular day, the testosterone levels were normal, androstenedione levels were low, which you would get with PCOS. Progesterone level was normal. They've broken it down to E1, estrone, estradiol, estriol. They were all fine. Estrone was a bit low. And then, like I said, you get different hydroxy estrones, right? You get the 2, the 4. This is not showing it here, but 16, you want the full picture. But doc, this is not enough for me. If you had to give yourself pregnenolone and then you did this test and I get the balance of the profile, then I can speak to what's happening with this Dutch pathway. But what I would have liked is to see that estrogen progesterone ratio. And with your symptoms, I do believe you need progesterone. And I think here the gynae is wrong. Based on, if I get those tests, I can say, you want to keep that estrogen in the first half of the cycle around 200, progesterone at least around 5 to 10. Second half of the cycle, if that's when you're doing day 21, you don't want the guy to go more than 350, in which case the progesterone needs to be between 17 and 35. And if you're going to do the LH, the estradiol progesterone ratio on ovulation, then it must be 1 to 10. And so it doesn't matter which test you use, right? But I would certainly work on it. You don't want too much iron. Thyroid's looking good. Antibodies fine. No insulin resistance. The hormone index is fine. So that's not the cause of weight. That's not the cause of weight, which means the estrogen dominance is potentially a part of the 3 kilogram excess weight. You indicated that you're on Vivo mix. So presumably you had some kind of gut microbiome test, and that can influence weight. I don't see the liver test. You did say you're on liver balance. You want the liver enzymes below 20, ALT and AST. Otherwise, that can contribute towards weight. And then you want your DHA and cortisol, very important from a fertility perspective. So a high cortisol can cause weight in the midriff area, but like I said, it can affect the fertility cycle as well. And then the last cause of weight and fertility would be mitochondria. I gave you guys a seminar on the mitochondrial test. By the way, I've got my first batch of tests. I think I got back the first 18 tests and showing very interesting results. Something we couldn't have picked up on symptoms, but more importantly, it guides you in terms of how to treat it. So here, doc, I'm not going to be able to help you more. I need that estrogen progesterone ratios, hopefully in more than one cycle, and I need that DHA and that cortisol, and hopefully somebody checked your prolactin levels. Then my husband had a semen analysis, which was normal results. Normal can mean many things, my dear. So to them, 4% is normal. I mean, that's like getting a 4% pass mark in your matric exam. You're not going to pass. So you want to first see how much sperm is being produced per mil. Is there enough mils? Then, are they swimming in the right direction? Forward mobility. What percentage of them are swimming in the right direction? What percentage of them are actually normal? What's the viscosity like? What's the agglutination like? Are there any genetic defects? All of that becomes important. A side note, my husband and my son both suffered serious health issues last 3 years, chronic stress. So of course, the stress is affecting you. That's why your DHA is going to be important. But hubby as well, not sure about the level of impact. Yeah, it does affect fertility. I'm curious about the best way forward and impact on letrozole, on estrogen dominance, interstitial hormonal imbalance, whatever. Listen, you can privately directly message me or send your results to Leonie, and I'm happy to look at it. But clearly here, I need a bit more information. All right. So thank you, guys. I spoke for 15 minutes less than I normally do. For me, that's a big achievement. My wife says I talk too much, and I agree with her. So, oops, sorry about that. So thank you very much for attending. Leonie will attend to your CPD certificates. For those of you that have jumped onto getting your mitochondrial tests with your clients, the report actually shows you how to manage those patients, but I'm happy to assist if those 2 webinars we had done was not enough. On the second webinar, we were told by the people who sent out the link that the link was sent, and he showed us proof that the links were sent. A lot of you didn't access and accept the link, and so 15 minutes before the second seminar, a lot of you guys were scrambling, and that's why the message was sent while I started. Leonie sent Chris a message to say a lot of people are saying they didn't get the link, and it was resent at 12 minutes past the talk. So it is available online or from Leonie. And if you haven't had an opportunity, that's where we were dealing with the meat of the mitochondria and how we're going to treat it. But the reports are quite self-explanatory. And now we have access to one more test, which is a very important pillar in integrative medicine. So thank you. Have a good evening. And we look forward to seeing you on the next talk. Thank you. Oh, I should have looked at the questions. Shit. Shit, I ended it. Some of you guys are still here. I forgot to look at the chat. Nadia says, please elaborate on phase 1, phase 2 liver detoxification. It's coming. That's the next seminar on how important the liver is. And remember, everything comes into the body one way or the other, and the liver is one of the organs that's got to detoxify it. Detoxify is a very non-medical term, but things need to be acylated, methylated, glycated, processed, packaged in a form that the body is going to be able to use, or once it's used it, get rid of it. So from that perspective, that's what it speaks to. And there's quite a few pathways, and we're going to talk about it in that next test. Okay, ashwagandha, and it's safe. You want to use it for fertility, it's fine, but it's safety in hyperthyroidism. Can you advise it's safe potential interaction with my condition? Yes, so it has more of an interaction on an underactive thyroid than over. And what if a patient has hepatitis? Like what kind of hepatitis? So it is safe to use, but infective hepatitis, the treatment is completely different. Whereas autoimmune hepatitis or fatty liver or NASH, yeah, it is safe to use. So I'll leave it there because there's no other messages. Thank you guys, and we'll see you guys next time. Thank you.